Thanks, James. Good morning, everyone. Pleasure to be here. Going to give the update on the home hemodialysis program and the activities we've been up to over the last year or so. Just thought it would be, it's always a good opportunity to come back, and I know that we're still one of the relatively small kids on the block when it comes to the grand scheme of things. But since the program started back in 2004, I think it's always useful to go back and look at just how much we've done. And if you look at the number of people that we've been able to provide home therapies to around the province in terms of the home hemo program, it's actually quite a large number over that time. So we've had about 700, just over 700 people come into the program. We've actually discharged home about 612 people, and we're sitting at about 150 to 160 patients for the most part with our numbers. And I'll show a couple of different slides here, and you'll see that there's some differences in the numbers. It kind of depends on the point that the time was taken. But that's representing somewhere between 5 and 5.5% of our total dialysis population, which is really amongst the North American leads in terms of the numbers. And certainly in Canada, Ontario and British Columbia are really the only two that are in that sort of ballpark. We've actually been quite stable over the last couple of years. This is just taking that number and looking at it in a percent. You can see it's somewhere in the 5.5 to 6% range for the most part. We had been seeing a bit of a decline of our new patients coming in, incident patients coming in, but if you look at the last graph, the BC total, you'll see in the last year or so that we've actually, for the first time after a number of years of actually having smaller numbers coming into the program, seen a bit of an uptick. And so we're hoping that that is the start of a trend that this time next year we'll be able to show you further increases of the number of people coming in. We continue to look at the departures from our program. And as you can see from that first slide, we've trained about 600 odd patients, about 150 of them right now. So a lot of people leave. And if you look at the reasons why people leave, a lot of people are leaving for the right reason. They're leaving because of transplantation. And I would also say a lot of people are leaving because of another right reason, which is sort of sounds funny to say it, I know, but they die. But fortunately, they're able to stay at home, and we're able to support most of these patients to not have to be repatriated back into the hospital programs. And I think there is a success in that, and that's something that we've been working hard at. We continue to struggle with what we loosely term technique failure, which is probably a grab bag of a whole bunch of different reasons why people leave. And we're going to continue to try to drill down a little bit more to try to find if there's things that we could do differently to try to preserve and keep those people on. Maybe a little bit analogous to the PD Assist program, though not necessarily a home hemo assist program, but just how we look at things a little bit differently. If we look at our ins and outs, the raw numbers, and again, you can see it's a slightly different time point here, but we're sitting at around 160, 163 patients over the year. That, if you look at that superficially, it looks like a fairly static program. But actually, if you break it down and look at the activities that are happening, what's happening is it's kind of like dialysis. What's going in is going out. And so our ins and our outs are sort of matching one another. And in fact, if you look at it over the course of the year around the province, we've brought in around 57 new patients to the program, but about 60 patients have left. So I think that's a really important thing that although the numbers have remained flat, that's not a reflection that the programs aren't busy. And I certainly think if you talk to the training, the educators, training nurses, they're pretty busy in terms of the work they're doing, both with new patient training as well as maintaining the patients at home, because there is work to keep people at home. As you know, we implemented a two-machine model, so we have a Baxter system as well as the Next Stage system, and this is just to break down what's happening in terms of our uptake, and we've seen a real growth of our Next Stage population, so we're up to about 50 patients. I think we're actually a little bit higher than that now. On the Next Stage system. And if you look at that little uptick of growth that we've seen of our incident populations, I think a lot of that is made up by the Next Stage patients coming in, and it's actually allowing us to access a different group of patients than we were necessarily being able to get with the existing system. So this flexibility, I think, is a really encouraging thing for a program to give us some options. This is a busy slide, but basically, if you look down at the median days in training on the bottom half of it, one of the hopes that we have with Next Stage is that it's a somewhat simpler machine for people to learn how to set up in particular. We're hoping to see that some of the training times actually gets a bit shorter. And if you look at the training times, we are starting to see that there's a bit of time savings. 50 days for Baxter versus around 37 days for Next Stage. And again, from a patient-specific perspective, that's a huge gain if you can spend less time in training. And we're working on some initiatives to try to shorten that even further for both machines by trying to look at ways to transition patients differently, maybe have them come in doing their own cannulation before they start their training. And a lot of our time spent in the training is getting people comfortable with self-cannulation, so we can maybe really shorten that even more. So I wanted to talk about the projects that we've completed over this last year, and there's a list here, and I'll go through each of them because I think there's a lot of really good work that's been done. I have the opportunity to meet with colleagues around Canada, around North America, as well as other places in the world, including Australia and Europe, and people are using the BC PRA website to pilfer our materials, and I think that's great. I think that's a testimony to the work that's done here. There's a lot of work that's done here. I get the honor of sharing it, but I do want to very much recognize that this work is done by a whole lot of people, not by me alone, and I'll identify at least some of those people. So one of the things that we've done, which is in place now, is to really try to make the experience, I think, for the patient more consistent. That's always been one of the themes we've tried to work on with the home hemo program. So as the patients are going through the home training program, they actually have a document that they can work with. And there's a number of tools included in this document that the patients are able to use. And it's something actually that the patients, if they had interest, would be able to look at even before they start their training, so they can do a bit of pre-reading if they're interested. But it talks about some of the physical assessments that the patients would do of their fistula as well as their fluid weights, et cetera, their evaluation of their access. It goes over the safety devices that we're using on the equipment, troubleshooting in emergencies, and then this is a tool that they have on hand for later on that they can always refer back to. And bridging in the disaster preparedness. So I think this has been a very useful tool. All these things that I'm going to be showing you, are, with the exception of one, are available on the website, and I'll talk about that one as well. One of the exciting things in the last year and a half with the introduction of the Next Stage is that we have actually been able to realize the possibility for our patients to travel. It's been a huge issue and a huge desire for patients. And frankly, many of the patients who are on home therapies are not crazy about going somewhere on a nice vacation and then going and doing 3 times a week hemodialysis while they're supposed to be sitting on the beach somewhere. So we have been able to put together a very comprehensive travel plan. One of the challenges is flying with this piece of equipment. And so a lot of work has been done with the Canadian airlines, the US airlines. The US airlines were already largely in place because of the population already down there, but with WestJet and Air Canada, and there's still bumps along the way, I'll acknowledge, but to help allow patients to travel with their equipment and for the airlines to waive the fees associated with baggage for the equipment. Included in this document, if you go through it, there's links to both the Canadian and the US Department of Transport. And so, you know, if the patient gets to the counter and the Air Canada rep makes a fuss, then they can actually pull it out and show them what the documents actually show. And I think that I've heard from a couple of patients that they have used that successfully with Air Canada. Hopefully nobody here works for Air Canada, but I love getting one over on Air Canada, so I think that's a great thing. Along with the travel, this is actually, it is a somewhat complicated process, I think, for patients to travel, and that's just the reality of it. But we've tried to put it into a document that gives them a step-by-step approach to how to do it, including, you know, making sure they're medically stable, so if they're planning a trip, to talk to their healthcare team about it. The transportation requirements here as well, not just for air, but also if they're loading it into their car or into their RV, which a lot of people are doing. A clarification about the medical services that we can provide. So it's an important thing for the patients to know that if they're traveling outside of BC, they can't really phone us and say, hey, I'm having trouble with my access, what should I do? Because once they're out of the provincial jurisdiction, we actually can't provide medical advice for them. What I tell my patients is to always make sure they phone me on their cell phone with a 604 or a 778 or a 250 number, and then I think they're in BC, just don't tell me that they're out of BC. Actually, that's exactly what CMPA told me to do, so that's a little trick you can do. But if they tell you they're out of BC, we can't actually help them, nor potentially should we try to help them. So they need to be aware that if they run into troubles outside, they can't do their usual routine of calling us and having us troubleshoot it for them. And it also talks about the supplies that they need. So it's a fairly comprehensive tool. And we've actually had a number of people, this is a little bit out of date, and it doesn't include the summer, so these updated numbers would probably be different. But we've had a lot of people that have been starting to travel. Not long trips necessarily, but getting away for a week or two. You can see different places around Canada that they're traveling, both within BC as well as out of province. And further afield, Hawaii, New York, France, Spain, Finland. I sometimes do get a little bit jealous of hearing about all the trips that my patients are taking, but I'm pretty happy for them as well, because that's been a huge part, and it is actually serving as a tool to talk to patients if travel is something that's important for them, that there are possibilities for doing that doesn't necessarily involve going back into in-center hemo, for our home population at least. Some other tools we have, and I think this is really building on a tool called the MatchD tool. I don't know if everyone is familiar with it. The MatchD tool is a tool that has been used to try to help identify patients who are suitable for home therapies. There's one for home hemo as well as one for peritoneal dialysis. And the MatchD tool, when it first came out, was a really useful tool. I've presented it in previous years here. Sort of says these are people who are good for it, these are people who are not good for it, and probably the most important column, these are people who might be good for it, but they have issues that you need to try to resolve. And so really what we've done here, in a way to try to standardize how we bring patients into home programs, because there is a lot of variability around the province as to how patients get assessed to come onto home hemo in particular. That this is a tool you can actually use and walk through with the patient as you're assessing them. And it includes some prompts for discussions and prompts for things you might need to consider with the patient. So I think, again, a helpful tool. And it's sort of MatchD with a BC flair, I would say. One of the other limitations of the MatchD tool that we found is that we would sometimes note that there were issues with the patient. Sometimes there were functional limitations, but we didn't have a really good way to formally assess them. And I think the access to physical therapy and occupational therapy is quite variable around the province. And so what we did is we worked with the occupational therapists in particular to look at some of the dexterity issues and look at some of the cognitive issues, and have created this tool that if you're concerned about an issue for a patient, you can actually walk them through, and it sort of takes you step by step how to assess the patient's dexterity, assess the patient's cognition. I don't have the whole tool up here, but it's all, as I say, on the website, and so you can have a look through. And I think that's a useful tool if you have somebody who maybe has some challenges to be able to approach it. I think the role that I would see of these sorts of tools are not tools to say you can't do home therapy. It's actually a tool exactly the opposite, to say, yeah, you want to do home therapy, we've identified an issue, let's troubleshoot it, make a plan for it before we start the training, and maximize your chance to be able to get home and put in place what you need. So again, really individualized care for these patients. The other thing we've done is we've taken a chapter out of the airlines. Not Air Canada, maybe. Oh no, Air Canada does this too. I've spent too much time on Air Canada recently, I think. So I don't know if you guys know, you probably do know, when you're sitting with those engines turning on, the pilots at the front are going through a really mundane checklist every single time. And that checklist includes things like make sure you've turned the lights on, make sure you've turned the oxygen on. They're things that you really shouldn't have to think about, but by doing this, it has had a massive improvement of safety in the aviation industry, and more industries are starting to look at the same thing. So we looked at that because dialysis is also one of these things that there's a lot of steps that happen. Many of them are sort of taken for granted in our routine. And one of the things that that we recognize as a big issue is infections. And so what we've done is we've retooled our hemodialysis log tool. So on the one side, you have the record that the patients are theoretically keeping track of what they're doing. But when you flip it over, and I know you can't read it here, but if you flip it over, it actually has a log sheet. And what we have is at least the tool that, in theory, the patient, when they're going through their hookup, can go through and just make sure that they haven't forgotten any of the steps. Now, we fully recognize the patients may not be doing it, but we've only just implemented this relatively recently, so it's too early to say what the impact is. But we are hoping that this will serve as a reminder for the patients and try to correct them as they're maybe making their own way on some of these things. We've also rejigged what we used to call the recertification, that we have a standardized tool that we use so that we can review what patients are doing in terms of their access management in particular. So again, the experience after a complication or at just a routine time of a reassessment is similar. And we've updated a couple of our guidelines as well, just for completeness sake. So we've updated our calcium management and also citrusate, and we were actually one of the first programs to use citrusate at home. So a lot of other programs are starting to use our documents for that. And then other stuff, waste management. We were getting some complaints from some of the municipalities about biohazardous waste getting in. Interesting fact, they can trace down to your address by your garbage, and they can find where that garbage came from to within 2 or 3 houses. Don't know, I want that job myself, but they can really trace it back. So if you lose your ring, just phone them and they can find it. But this is actually just a stepwise tool that patients can use to make sure that and we've worked with the municipalities, it makes this non-biologic hazard for the landfills, and so that's now implemented as well. A boil water advisory. Some of these are the things you don't really think about in the hospitals, but if we have a boil water in a community, particularly for our patients who are on next stage, who are on a deionizing system rather than an RO, we have to have a backup plan for those folks because the DI can't necessarily handle a boil water advisory. So we have a plan in place for our patients, basically using some pre-made bag solutions. The other thing I wanted to touch on, and this is not on the website yet, I don't know if Dr. Singh talked about this from her PD. I missed her talk this morning, but this is, I think, I'm really excited about this tool. This is a tool that was created with patients. So after they finished their training, there was a period of meeting with a number of patients who just finished their home training, and it was really, this is what you got, what do you wish you had, what did you need to know that we didn't know? And so this is really designed by the patients for future patients. And it's a really nice stepwise thing that you go through, and there's all the different levels in it. There's 6 different levels, right from the point of considering home therapies through to your training. Each of the sections are divided this way: questions to talk to my healthcare team about, things that I need to decide about, and then help that patient to transition through each of those different steps. So it's not on the website yet because we're just trialing it right now at VGH, just to make sure that it's a tool that's working. But I'm anticipating probably early 2019 it will be up on the website and available for use. And again, to our knowledge, these documents are amongst the first that have been done anywhere in the world for this sort of a process. So I think that's great, and it is very patient-focused because it's from them. It includes, and again, you can't read it here, but it includes a pathway for the healthcare providers delineating the role of the home team versus the role of where the patient is coming from, be it the kidney care clinic, the dialysis unit, et cetera. So again, it serves as a tool to help transition those patients efficiently and easily. My last moment here, I just really want to acknowledge, and I apologize if I have forgotten names on here, but the work that I've presented is the work of many people, and I'm very thankful for the work that people provide. I do want to actually call out a couple of extra kudos to Sarah, to Sue, to Bill, Sidonia, and Claire. They're the ones that are emailing and keeping track of everything on a day-to-day basis, and are really I'm a very small cog in the gears that they keep going through the program. So I really want to thank the whole committee, but also those individuals in particular. And I'll stop there. Thank you very much.